Okay, we're going to go through some bone radiographs and highlight just a few basic things. Okay, these are our learning objectives, just trying to look at basic bone anatomy, what's the cortical versus medullary bone, looking at, you should know specific regional bone structures that we did during your first year, and we're going to see different types of fractures and how we would visually identify them. We're going to talk about periosteal changes as well as some bone lesions. So we'll start off with bone anatomy. We've got long bones. They're capped at the ends with hyaline cartilage within the joint regions that are encapsulated by ligaments and lined by synovial membrane. These structures are not visible in radiographs. The bony anatomy includes the ends or epiphyses, the shaft, which is the diaphyses, and the flaring ends are the metaphyses. The diaphysis is centrally filled with fat or yellow marrow, while at the metaphyses and epiphyses we find the red marrow or spongy bone, also known as trabecular bone. Here we see a cross-section of the diaphysis below and the epiphysis above. Note the radiograph with the starkly dense white cortical bone in the diaphysis and see how it thins out as it extends to the ends. Here's a clearer view of cortical bone. Along with a diagram on the left, so the bone's on the right, and we can see the medullary bone in much finer detail. Here's an example of the differences in the medullary bone from normal on the left to a patient with osteoporosis on the right. Notice how the cortical bone also appears thinner in this patient. So now, in order to find fractures, we follow the cortical bone to assess for its integrity for smoothness and continuity. Look for the smooth borders all around every bone. If you see a disruption or a crumpling or buckling of the cortical margin, as seen in this child's distal radius to show that there's damage, this is a buccal fracture where the bone buckles instead of breaking, and therefore it's still a fracture, but an incomplete one. Has the fracture resulted in cortical bone discontinuity that looks like a dense line on X-ray? This would be because the cortical bone on both sides of a fracture plane are slightly overlapping. Or is there a lucent line because cortical bone on both sides of a fracture plane are separated? When assessing for fractures, remember that a single view can sometimes tell a misleading story. For a diagnostic assessment for bone fracture, do not settle for less than 2 views. With an acute fracture, the bone disruption will appear fresh, with sharp edges along the break and no callus bridging the fracture plane. With a subacute fracture, typically a few weeks to a few months old, the lucent fracture line will still be visible, but around 1 to 2 centimeters of bone reabsorption has now occurred, along with both sides of the fracture, resulting in a fracture line that appears more indistinct. You may also see early callus formation bridging the fracture plane too. With a chronic fracture, the bone along the sides of the fracture will usually have fused and a lucent fracture line is no longer visible. Smooth callus and remodeling may have also occurred, resulting in a localized deformity in the shape or contour of the bone. Now the type of fracture should be identified. Some fractures, particularly those in kids, may not result in a clean break, so they're considered incomplete. This type of fracture is called a green stick fracture. Most fractures, however, are complete. Complete fractures are subdivided by how the fracture plane runs. Here we see an example of a transverse fracture that goes through the cortical bone perpendicularly, and an oblique fracture at an angle. And here a spiral fracture resulting from a twisting force, so it resembles a corkscrew, or a longitudinal fracture that runs parallel to the long axis of the bone. The fracture also has to be categorized if it's closed with the skin intact or open where additional complications can occur with the exposure to the outside environment. Describe the number of fragments. Simple fractures result in only 2 fragments. If more than 2 fragments are present, the fracture is comminuted. The orientation of the fragment relative to the proximal fragment is also noted, along with the amount of displacement. Here are a few examples of how these would be described. Finally, describe if there's joint involvement by the fracture plane. Intra-articular fractures like this one extend into a joint space and may substantially affect joint function and lead to accelerated arthritis and often may require open reduction or internal fixation. Now we'll go through some periosteal. Back to bone anatomy, I like this image because it shows the hard cortical bone of the diaphysis and the peeled back organic outer membrane called the periosteum. The periosteum is collagen filled and is what anchors the tendons and ligaments. The inner lining of the diaphysis on the inner edge of the cortical bone is where the endosteum is found. Note the periosteum is a normally unseen outer lining of the cortical bone. So sorry for this. This is a gory slide. It is a raw elk knee without any preservatives before it's being cleaned up. The purpose of showing this image is to see the periosteum. So we're zooming in here on the right and you can see where there's regular hard cortical bone, then this organic flexible membrane that's tightly adhered to it. I have to use a scalpel to remove it from the bone. When cortical bone is insulted and the periosteum is torn, stretched, or inflamed, a periosteal reaction may occur and lays down a new layer of bone that's often visible on radiographs. In this example, the yellow arrows show the subtle periosteal reaction as seen on a radiograph. The periosteal changes tell you something about what's going on, like a fracture, infection, or tumor. The periosteal reaction pattern tells you about the underlying bone process. When you notice the presence of a periosteal reaction on an X-ray, it's an important hint that there's some sort of cortical bone insult and that the periosteal reaction pattern may help suggest if the insult was non-aggressive or if the insult was aggressive. When you see a thin line around bone, it can be from something like a fracture or an even benign tumor. Here's another example, but this one's more solid. When you see an onion skin or layered appearance, this is an aggressive periosteal reaction and indicative of something more serious, such as acute osteomyelitis or a malignant bone tumor. Perpendicular hair on end is another aggressive periosteal formation, as well as the sunburst periosteal reaction pattern. So looking at some specific bone lesions, the most important factors in assessing a bone lesion is the age of the patient and the location of the lesion, which bone, central or superficial, proximal or distal. Bone lesions can be of different densities due to different bone modeling. On the left is a lucent lesion of a patient with giant cell tumor of bone. The bone is being destroyed in this well-defined region. In the middle is a sclerotic lesion where there is increased bone formation from metabolic diseases, infections, or tumors. On the right is a mixed lesion where we have both actions happening across the bone. This is from a patient with fibrous dysplasia. This is a nice diagram showing the progression from least to most aggressive types of lesions, starting on the left with a well-defined area with a very sharp sclerotic border, which progresses to loss of that border, or in the middle where it starts to lose the defined nature. The two on the right are more dispersed across the bone, with the type 2 commonly described as moth-eaten, while the last is just so spread out and diffuse throughout the bone. We can see actual patient image examples from each of these types of lesions. On the right, type 2 mothball appearance of multiple myeloma, hard to see where it starts or ends. The type 3 is a Ewing sarcoma, ill-defined, diffuse, it's very aggressive. Here's another nicer image to show the nature of the lesions within bone. Back to periosteal involvement, we see this diagram showing increasing aggressiveness. Here are some imaging examples of these. Far right is the Codman triangle. This is where a lesion grows faster than the periosteum can grow new bone. Here we can see in this image the Codman's triangle as well as the periosteal reaction. In this schematic, the periosteum and the tumor are more clearly delineated, with the top protruding angle in yellow. And that's it for bone assessment.